Well, hi everybody. I'm Rich Stevenson. Hi Barry, how you doing? I've got Barry
Hi,
Ringo here.
Rich. How are you?
Mark is with us in spirit. He couldn't make it today, but we've got, I think, what's going to be a very insightful and helpful discussion and plan for you guys.
Yeah.
So let's start with looking at, we have the airway courses last weekend. It was really wonderful.
Yeah.
Barry was
Pretty
able to,
exciting.
yeah, it was great. Barry was able to join us via Zoom, and it was like you were there in the room. And you very, very favorable reviews from all of the participants. Everybody's committed to the next level. So that's very exciting to me.
Yeah. It
And
was exciting to me too, because you know what
good.
it is? The first kinds of things that people experience in the course is a certain awakening. Even if they've been exposed to the airway concept before, they usually are experienced with, being introduced to some of the widgets, some of the
Right.
appliances, as if the appliances themselves are the crux of the matter. And when we elucidate the metrics and the phenotype markers for the structure, function, behavior triad, it's as if there's an awakening. And you can see it happen by the end of the weekend that they and they haven't even seen any patients yet, but
Right.
in their minds they already know what they're going to see Monday and how different it's going to be.
Absolutely right. I agree, and I mean that's really what I'd like to talk about. And if you can, let's just start at the beginning where we would perhaps what is it that we're looking for from a phenotype standpoint in the way of structure, and then we can talk about function and behavior. But what are some of the things that should alert us to potential problems with airway, with breathing in our kids? We could just keep it focused on children
Yeah.
for now and see where that goes. But Barry, what for you are the things that stand out when you see a new kid come into the practice that you just know immediately this child is in distress?
Yeah, and let me take a little bit of a step back from that and talk about this milieu that we're in, where we've understood for a long time that human beings were born to have 32 straight teeth. And the only way that that can happen is if the jaws fill out fully and properly and to our genetic potential, which is what was true for hundreds of thousands of years, but only in the last few hundred, and frankly, especially in the past 100, it's been getting worse. Have we been exhibiting this change in shape of face, which is becoming endemic
Yep.
and universal? It happens anywhere in the world that we transition from an ancestral kind of feeding to a industrial kind of feeding. When we transition from clean air and water to environmental stressors, let's just put it that way.
Right.
Um, when we transition to using our bodies to travel across the earth on foot, looking for opportunities to feed and gather, to hunt and transition to a world in which we are sitting in chairs all day, staring at computers like we are at the moment,
Right now.
with our heads bent forward. And I just, the world is so incredibly different now than it was when our bodies were designed for survival. And the changes have been so much more rapid than genetic change can occur. So what we're looking at, to answer your question, in detail, um, is is sometimes hard to see because it has become so normal. And
Oh,
that, when I was in my residency, within one generation, we went from 50% incidence of crooked teeth to 80% incidence of crooked teeth, which means that even within one generation, there's been a significant worsening of this problem. And many people and practitioners certainly overlook them because everybody seems to look this way. So, from a structural point of view, we're looking at that downswing of the lower third of the face. And it's got lots of little details, and it gets wrapped up in the habits, for instance, low tongue posture or mouth breathing, and forward head posture and attempts to keep the airway open. But uh, there is a variety of phenotypes that occur, um, uh, based on the kinds of habits that were selected or adopted, the compensations that were adopted, the genetic background, the kinds of various stressors that are occurring. So yes, we see a wide variety of things. It's no one thing. We used to talk about adenoid facies,
right.
and it's probably one of the facial phenotypes that most orthodontists will agree is a sign of poor development. But there are others that just are not really seen that much. So, when we're teaching it, we're teaching the wide variety of phenotype changes, but have to understand they also come in a wide variety a wide variety, and of facial types. That's what confused orthodontics when Angle made his classification. He knew that humans that grew up with straight teeth and had 32 straight teeth, they had a mesiobuccal cusp of the upper first molar coincident with the middle groove of the lower first molar, the classic Angle class one. And from the point of view of wanting teeth to fit together better and work together better and glide over each other in good function, well, that all makes sense in a well-grown face. But when the face doesn't grow well, when there's a mismatch between the upper and lower jaw, when there is um, even if they seemingly matched, but there's a detrimental effect to the growth of both of the jaws, that expecting the teeth to fit into that Angle classification, it doesn't quite make sense.
Correct.
And so what we look at, from teeth point of view, it almost doesn't matter so much. The Angle classification is misleading in that it doesn't really tell you about how the teeth got crooked.
Mm-hmm.
And, if we have any orthodontists listening, that's not an easy thing to swallow, pun intended. That we use the Angle classification as a diagnostic rubric, as a treatment planning rubric, and as an outcome measure.
Right.
And if we don't achieve class one, then we feel that we've failed, basically. But when you look at the other phenotypes of anatomy, you realize that it's almost silly to expect the teeth to have to fit into a poorly shaped face in that Angle classification. And the problem with orthodontics is we bend over backwards to force the teeth into a class one a good alignment, whether we take out teeth or distalize or expand or whatever it is, but we're forcing the teeth into a situation that they just don't feel comfortable with. And what do? Then we glue the teeth together with retainers, wear retainers forever. And we, of course, blame the patients when they don't wear them,
Right.
right?
Right.
So, all right. So let's stick to the topic there. And you see this stuff.
Oh,
The
well,
open mouth posture is probably the biggest one because that has a functional effect. Baby teeth that don't have spaces is one that flies under the radar so much, both with parents and unfortunately many pediatric and general dentists. They won't make mention of anything if the baby teeth look like they're straight in a mesial step occlusion
yeah,
because
I was gonna just jump in and
yeah,
tell you that I was speaking to a patient of mine that was seeking a second opinion, and her orthodontist, well, maybe it was general dentist that did ortho. I don't know for sure, but basically told the parent not to intervene at all, that everything was fine, and wait
yeah,
until the permanent teeth erupt. And
yeah,
this little girl was severely, compromised, and yet there was this sort of opinion that the child will grow out of the problem. Okay,
mm,
and we know that just simply isn't true,
yeah.
and that might be an interesting point to talk about too. Is that
Right. If it were true, then 13-year-olds would have straight teeth.
there you go.
It's 80% of them don't grow out of the problem.
Correct.
Right, right. So, what did she look like?
Oh, long lower jaw, mouth breather. She had scleral shine. She had venous pooling.
Uh,
Her ears were out here. It's just classic poster child of a suffering individual,
right,
10 years old,
right.
and probably should have been uh, receiving care much earlier.
Yeah. High narrow palate,
Oh yeah,
crowding of the teeth.
exactly.
Yeah. Downswing of the lower part of the face, chin
Yeah,
setback, and all
yeah.
that. Yeah. And, I mean, quite honestly, I have some kids that come to see me. They are cute and they fill out that lower third of the face.
Hmm.
And it surprises me when I hear about the functional piece. So this is where it can get confusing. It's not just the structural piece.
Right.
It's how is that person functioning within this chronically stressful environment that they may not have as many anatomical compromises
Ah, right. So
as they
how do we catch that?
right.
That's a curious one.
Right. So then besides looking at just the anatomical phenotypes that seem to be obvious,
Hmm.
we have to look at the functional the functional responsiveness and resilience of the being and how much distress they're in. So, and many times when you learn about these techniques where you're learning about the widgets, this appliance opens up the palate and the airway. And if you use it, then the child won't have sleep problems anymore. Or if you use this mouthpiece that teaches nasal breathing and cleaning and clear and good tongue habits, then you won't have sleep problems anymore. If you do myofunctional therapy or craniosacral therapy, any one of those things alone can be very effective at times, but may not really address the problem at all. Well, I wouldn't even say at all. I mean, that usually these techniques will have some influence in some of the cases, a lot of influence in a couple, but it's a bell curve of results.
Sure. So,
But if you look at the functional problem,
right.
that's when you start having to measure the medical indications.
So let's go back a little bit and outline for our listeners what the obvious patient is going to look like, that is going to, that we know without question is going to require intervention. And then what what are the clues you look for in the patient that looks balanced and, like you said, cute kid, everything looks all right, and yet they aren't functioning well? How do you pick
Right.
up on those cues?
Right. Well, I mean, let me reframe that question a little bit because I do have some kids that look sick but are functioning well. And
Mm-hmm.
I'm less likely to intervene for somebody that might have anatomical deficit, but they seem to have compensated very well. Now, I'm also looking down the line 10 years, 20 years, 40 years. Will that anatomy be able to support good function, through the ages?
Right.
But in a way, the major question that we're asking from function is just how much distress is this being in? And not psychological stress, mind you, although it can lead to that. We're talking about the physiological stressors of functions that are being overtaxed. People talk about toxic load, for instance.
For sure.
So our bodies are meant to handle stress. It's not like we need to live in a stress-free environment. In fact, a certain amount of stress makes us stronger. But there's a certain amount that we can take beyond which then we start expressing symptoms of all sorts. That capacity to process and be resilient to stress is actually a measure of health. And there may be a very fine line between being able to do that and then being overloaded. What is the straw that breaks the camel's back? There's all kinds of debate about what these different stressors do. I mean, you look at the debate about vaccines did the vaccines cause this or that, and what's the data around that single piece? It's almost it's almost silly to try to pinpoint our chronic distress on any one stressor,
Mm-hmm.
because almost always it's a combination of many, and which one throws you over the edge.
Very true.
So, you could say it in lots of different ways. Vaccines may not bother a lot of people, but they may bother the people that are on the cusp of being overwhelmed. Or you could say that about mouth breathing and the way it engenders the physiologic changes in breathing biochemistry, right? Just the way that carbon dioxide changes the association curve of oxygen to hemoglobin,
Mm-hmm.
um, can change momentarily based on the way that we breathe and handle oxygen. And for some people, that may be the thing that throws them over the edge. Maybe it's not.
So if you're looking at a kid that looks like they're suffering but they're not, or you're looking at a child that looks terrific but they are suffering,
Right.
Those represent sort of the two mysteries. And
Yeah.
on the one that has structural adaptations that is doing okay, you're going to have to think about, right, what might happen in 5, 10, 15, 20 years, whatever, on that
Right.
patient. So you're probably
Yeah.
treating to, on that patient, you're treating to, let's just say, the new orthodontic standard that you practice, or are we going down a different pathway for that particular that patient? Is there a sense
Right.
of urgency with them, or are you telling the
Yeah.
parent they can stay untreated for a while? How are you
Right.
handling that?
Right. Well, you want to make sure that they continue to grow well.
Okay.
And if it happened by happenstance that they have not succumbed to some of the habits, they didn't have to compensate for some of the habits that would throw their growth awry, you want to make sure that they continue to do that. We certainly know of examples of children that were doing fine until they encountered some stressor that put them over the edge. That very famous story about the boy at 10 years old who got a gerbil or a hamster or something, uh, a rodent pet at that age and was allergic to it and had no idea, right? The dander was in the room, and over the next few years, it created nasal congestion and then open mouth posture and then breathing and then change in the face. And 5 years later, you look at his picture, it doesn't even look like the same kid.
Wow.
And we do see that patients bring in their baby pictures or their toddler pictures, and they had beautiful faces, but now really going downhill.
Hmm.
So how do we make sure that someone who's growing well, even if they're not exhibiting medical indications, how do we make sure that they do grow well?
Hmm.
And really, underpinning all of this, whether it's the structure or form or the function or physiology,
Hmm.
I mean, orthodontists been and dentists too, I guess, been polarizing about the form and function spiral for hundreds of years.
Hmm.
I mean, I know that the cycle of form and function, which one takes priority, has gone through at least 6 cycles within the history of orthodontics. And yet, to pick a side, to polarize around that issue is really inane. It's sort of like polarizing around which is more important, the chicken or the egg.
Right.
I mean, if you want a chicken, you need an egg. If you want an egg, you need a chicken. It's not which came first or which is more important. It's the spiral that's occurring.
Right.
When the form and function spiral, it's either going towards ill health or to better health. And the thing that makes that happen are the behaviors that support it.
Hmm.
And if the behaviors are ones that are compensations for our inability to, function optimally, then that spiral's going to go downhill. So I'm always looking at the behaviors.
Hmm.
How well can a child breathe? How well do they eat? How well do they sleep? Well, how's their posture? How's their well, I said eat. I mean, they're like 4 or 5 basic things that we have to look at. And usually, because of our modern environment, there's a compromise or a compensation in one of those things. So, how do I keep a good looking face to stay good looking? I make sure they have good habits.
Hmm.
And maybe I don't need a palate expander, but I still need the tongue on the palate,
Right. So how do you
right?
do that?
And
How do you get the kids to keep the tongue on the palate, or how does that? How do you make them?
well, how do you get a kid to brush their teeth? How do you get them to read? How do you get them to dance or play football? Got to teach them.
Right.
I don't know why people think this is so hard to teach kids good habits when we're teaching them good habits all the time.
True.
It's part of our culture.
Mm.
We've developed a whole industry, as an industry, a whole system for helping kids grow up with strong minds.
Hmm.
It's called education.
Right.
We have a little bit of a physical education thing, and we have sports, which is good. I mean,
Uh-huh.
that's a way of helping a body grow.
Sure.
We teach kids how to brush their teeth. Mothers, who say, "How am I going to teach my kid to clean his nose?" I go, "You teach him to brush his teeth. Do you ever let him go to bed without brushing his teeth?" They go, "No, of course not." So, we
That's
teach
awesome.
a child to brush I mean, to clean their nose and clear their nose. There's some very basic habits that we teach and exercises and I use them myself. It's
Yeah.
not like you teach them and then you don't need them anymore. We're teaching life skills. How to keep your nose clean and clear it when you lie down. If it gets stuffy, yeah, you got to sit up and get the fluid out or wash it out or blow your nose. I mean, it's just not, it's not been part of our culture, and
Yeah.
it's so important. So those are the behavior habits that underpin the structure and function. So that's why we claim it to be a triad and
Yeah.
and push that comment. And I think the concept is catching on. I do hear other practitioners talk about it. I hear other um, educators now talking about the structure, function, behavior triad. And to the extent that they really know, can do the phenotyping to look at structure,
Hmm.
can do the medical metrics to look at the physiology, and can define what compensations are at play, then I think they're on the right track.
Yeah.
Yeah.
Yeah. I agree. I was thinking, there are some things that we do that um, some disciplines will look at as like that is going to take care of everything. For example, not going to name names, but let's say there's an appliance that's not even bonded in the mouth. It's something that can be easily taken out,
Yeah.
low cost. There's a whole system built around that approach.
Hmm.
There are those that are of the belief that myofunctional therapy in itself can be extremely successful. Almost to the point where nothing else needs to be done. There are some philosophies where removable appliances that are more in contact with the teeth, or maybe lighter forces are at play, and it just seems like there are the airway treatment options, or the marketplace is confusing. And there's and it's like you were saying earlier, it's not any one thing. You have to be able to adapt and understand what each of those brings to your to your case, to your objectives. And but and I think a lot of dentists, and I get this, a lot of dentists are just, we're just not exactly built that way to think stochastically. We're just like, give me a procedure or a thing, let me glue that or attach that to the body, or put it inside of a hole or make a hole. And we we want that simplicity and that predictability. And
Right.
it's a pet peeve of mine, because we're just not built that way. Things don't work that way. Nothing lasts forever. And it's We don't treat things, we treat people. And it's so much more complex than that. Um, in our teachings, Barry, we we make it much more clear how to implement those different modalities at different times. And but it would be good if you could give us some clarity on how you see them fitting together,
Mm.
like and providing uh, the the airway focused dentistry. How do we draw from all of those? I mean, what does that look like?
Yeah.
A lot of stuff there, but I mean, I want you to.
I think I can unpack that.
Okay, good, because I want us to get off the widget, bullet train that so many people
Right.
are on.
Right.
And
Right.
I mean, my gosh, there's conferences that are named after the widgets
Yeah.
or the technique, and I
Sure.
think that can't be the sole answer. So,
Yeah. Yeah. When I started getting into this, I started taking a couple of the widget courses,
hmm
and one in particular, I walked into the room. There were 25 students,
okay.
and they were all general dentists.
hmm
And they said, "You're an RO?" I go, "What's an RO?" They said, "A real orthodontist." I go, "Yeah, but what are you doing here? ROs don't come to these courses." And I learned that RO is not exactly
It's not a complimentary
it's kind
term.
of a pejorative term, right?
It is.
Yeah, yeah, yeah. So, but on the other hand, I started understanding if I'm going to be a specialist here, I really need to know at least a little bit about everything that's being done in this field. You might say jack of all trades, master of none, but
Hmm.
the metaphor that I'm thinking about is the saying where that, if all you have is a hammer, everything looks like a nail.
Hmm.
So if all you have is widget A, it looks, that's what you're going to use for every case because that's what you've got. But if you were a carpenter and only had a hammer, you just wouldn't be a very good carpenter. You would need a saw and a plane and be able to use and screwdrivers. You need to have a variety of techniques and get good at the techniques and good enough so that you can use them in combination to create the piece of furniture or the house or whatever you're making.
Very
And
good.
dentists do know this. I mean, how many restorative materials have you been taught? You were taught amalgam, probably. You were taught composite. You were taught porcelain. You were taught gold. You were taught onlay, inlay.
hmm
Um, and you look at a tooth and you weigh the pros and cons of the various techniques. And maybe the patient input, has something to do with it. And, we are trained in many different techniques. It's just that when you're getting into this new field and a new way of looking at things and new problems to solve, well, you got to start somewhere. Orthodontists tend to start with palate expanders. Why? Because they're all taught how to use a palate expander. So that's like a simple, logical place to start, which is fine. And a lot of maxillas need to be widened. But then you start learning that the maxilla is also collapsing in two other dimensions of space. It's failing to grow forward, it's sinking downward. And now all of a sudden, the palate expander becomes one part of the solution. And what are the other parts? And so you need to start broadening your base. Plus, what works well with one patient does not work well with all patients.
hmm
Um, I use a lot of those myofunctional orthodontic trainers because I know that if they are well worn, they will correct muscle function and jaws will start to grow better and teeth will start to get straighter. And it's amazing what it can do. I can tell you stories of how I was blown away by 10 Chinese orthodontists who showed me their best cases with a myofunctional orthodontic technique, and I swear I never achieved anything as good. And
Mm.
I said to them, how did you do this? I was supposed to be the expert, judging them for God's sakes. And they said to me, all of them agreed, Chinese children do what they're told. And and it is a cooperation based technique. And if you're going to change behavior, you have to change behavior or you can't change the outcome. But are American kids like that? Not in my practice.
No.
There are many kids that frankly can't even get off the ground with these techniques. Why? Because their nose is so clogged that they cannot be asked to breathe through their nose as a starting point. And so oftentimes I'll spend a good 3 months just trying to discover what kind of resiliency the child has. What can they handle? What are they willing to handle? What are their parents willing to handle? How structured can they be at home to do these exercises every day? Are they willing to change a behavior?
Is that a
How
patient where you might opt for an expander to
Oh, yeah, absolutely.
quickly
Because,
decompensate them?
right. And this is where that question about distress comes in, because the more distress a child is in, the more you want to get them out of distress quickly.
Right.
So, on one end of the continuum, we kind of rely on the body's natural wisdom to be able to grow and develop properly. That's our genetic birthright. And the modern environment gets in the way in lots of different ways. The trick there is to get the obstacles out of the way and let the body's wisdom take over.
Hmm.
But when a child is in a lot of distress, when there's been a lot of physical damage to their facial growth, when there's a lot of physiologic reactivity and sensitivities and mucus and all that, and especially if they're not breathing well and they have knockoff daytime behavioral problems because of it, you don't want to wait for the body to take over. You need to help this child out. And so that's when we become a little more active and therapeutic in our modalities and take control. Orthopedic remodeling with expanders, whether they're transverse or sagittal or vertical, those are all really important things to do to try to get the child back on track. And then once you get them on track, get the nose open a little bit, get them breathing, teach them to use their diaphragm, settle them down a little bit, a little more autonomic balance. Then you can go back and nurture some of those natural growth tendencies. So, the five, six elements of the continuum of care are natural growth, where we support natural growth, often done for infants or even prenatally. There's lots we can do to help children get off to a good start. Biomimetics is where we're trying to administer things that mimic natural stimulus, where we just add a little extra input into the system so that we can get those natural systems revved up again and going again or balanced again.
Right.
Um, Growth guidance is where we become a little more active in pushing the bones a little bit, making sure they're growing forward in the face, making sure the palate is opening or blossoming in a way.
Hmm.
But and getting the mandible to be able to have a place to grow without interference from either the structure or the muscle function. But then comes orthopedic remodeling, which is where we're using force on the body to really, I mean, it's sort of like I'm trying to think in terms of remodeling your kitchen. Sometimes you need to push walls out of the way or
Right.
take 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 old cabinetry off and put new on. And then the fifth is orthognathic surgery. This is where we're going to take walls down and put them back somewhere else,
Yeah.
to make a bigger room. And that's literally facial carpentry, taking parts apart, screwing them back together.
Right.
And that's not the way the body wants to be treated. There are definitely drawbacks to that, and yet sometimes those are the most effective cures. So,
Usually in patients that don't have any growth potential, obviously that I mean that's what I would where I would utilize
right.
that approach,
Yeah, yeah,
right?
yeah.
So okay, but not in kids.
Well, all right. So if we have kids that have craniofacial anomalies that are
Okay,
especially, yeah, we're
we need
doing
to
orthognathic surgery
gotcha,
in
gotcha,
them.
gotcha.
Yeah. I
Okay.
mean, and every child presents their issues. The trick is trying to figure out where you're going to be
Mm-hmm.
and in what order. Because there are times when I want to start with biomimetics, be nice and gentle, teach the tongue to get on the palate, change some habits. But if that doesn't work and they're still suffering, then I'm going to move them up to orthopedic remodeling. Or I'll start with orthopedic remodeling and get the palate open and a place for the tongue, and then I'll go back to biomimetics and release the tongue and teach the myofunctional principles and all that.
So you'd
You
put
know,
tongue tie releases, lips releases in the biomimetic treatment category.
well, there's lots of overlap. I
Okay.
mean, in a way, releasing a tongue is a surgical procedure,
Sure, sure.
you know, but it also has to be done in the context of teaching the muscles good function. So, oh, I say six elements. The sixth one, by the way, is orthodontics, which is just that's sort of the last step. That's the window dressing of facial growth, right? You finish building the kitchen and now you're going to put up some wallpaper or whatever, arrange the kitchen table and the chairs. Maybe a better metaphor for that. It's the last thing you do after you get everything else done.
Right.
But
I'm sorry. I just this is
uh,
it's on my brain. I wanted to ask you this because
yeah,
when you're going over the spiral or the the
form
contest
function.
between
Yeah,
structure and function
yeah,
is the Frankel appliance that I saw 30 years ago. Is that an
yeah,
example of the camp, the
yeah,
functional camp?
yeah, yeah.
Boy,
For
was
Ralph
that a
Frankel,
oh my goodness, that was quite an appliance. It was
it was
so
quite
unusual.
It was unusual. It is quite an appliance. It trained good muscle function as a way of
Wow.
changing form.
Okay.
And I learned it in my orthodontic residency. I built
Okay.
one. And then when I got out, my very first best case, the one I was the proudest of, was a Frankel appliance. And I
Huh.
probably did 5 or 6 of those cases,
Huh.
but it took an unusual patient to want to wear that throughout the day.
Got it.
And some, didn't make it to the end of treatment.
Right. Right.
And then I had to pick something else, and this is that last point that I wanted to say is that you need to have the kind of flexibility to have a broad range of treatments so that you can be a little more flexible with the patient in front of you. And as frustrating as that can be, and as challenging intellectually, professionally, treatment planning wise, even expense wise, as frustrating as that can be to bounce from one thing to another, this is really the way the body works.
Hmm.
Our bodies are complex systems, and we've run into trouble because we've become so siloed within our professions of looking at just one part of the body that we ignore the rest of the body.
Oh, absolutely.
In systems-based medicine, we have to understand that one problem could have 100 cures. And one cure can solve 100 problems. It's an old Eastern philosophy,
Mhm.
but it's a testament to the fact that the body itself is complex enough that every case is somewhat different and unique.
Mhm.
And to think that you can handle all these things with one approach just doesn't make sense.
Got it. I, I I wanted to know if you think that algorithms need to be more clearly presented in this field of airway to help clinicians basically not make the mistakes, or do you believe that a certain amount of wisdom and expertise can only be obtained through the pains of making decisions that are either inappropriate or maybe just not helping?
Yeah.
Is that just the way it goes? I mean, is there a way to short? Is there a way to leapfrog
Yeah.
a more experienced
You
position?
know, one of my mentors um, developed a simple protocol to follow, and his premise was that if you make this new concept to people too complex, that they just won't buy in. And he did manage to get a lot of people involved. On the other hand, the system just doesn't suit itself to such a simple way of looking at things.
Mm,
You have to start learning the exceptions, and then the exceptions become the rule in a way
mm,
that maybe you keep it simple to get people started, but I kept telling him, I go, you're insulting my intelligence. I'm a doctor.
mm-hmm,
I am not just a mechanic. And we feel that the things that you need to learn are not something simple. We tried to say we're not going to tell you what to think. We're going to tell you how to think,
mm,
teach you how to take the various components of all the metrics and phenotype markers and all that and put it together and have a way of thinking about it so that you can break into the form and function spiral and make it and start to reverse it. And when you develop that kind of thinking, then yes, you may have to take advantage of the skills that you have. And if you don't have enough skills, you may have to collaborate with someone who does. But you'll have a rationale for making that referral based on what your patient needs. And the one thing that I think maybe simplifies this in some ways is that form and function spirals can have many, many layers to it.
mm-hmm,
Like, say somebody starts with a fever, and then their tonsils get swollen, and then their nose gets stuffy, and then they open their mouth because they have to breathe, which is an important thing. And then the face starts to get slack, the muscles start to get slack, and then the palate starts to collapse, and then the muscles get weaker, and then the teeth come in crooked, and so how many layers of that? And I've drawn out some form function spirals that are maybe 12 layers or 20 layers deep, and when you start looking at some of the other physiology, that it can even be deeper than that.
mm,
But the point is that it almost doesn't matter where you break into that spiral to start to reverse it.
mm,
You can break in on the form side, or you can break in on the function side, and you can break in down by where the etiology is, or you can break in a little bit higher up where some of the downstream effects are. But you can start to reverse the downhill spiral by taking care of one thing and then another and then another and then another, and soon you're starting to reverse it, and you can see it in the kids where they're starting to breathe better, they're starting to keep their lips closed, keep their tongue on the palate, getting a better night's sleep, doing better in school, having more fun, just healing.
Hmm.
And that's what we all need. I just, in medicine, for many of the areas in medicine, it becomes what procedure do they use? What pill do they give?
Hmm.
And I don't want to replicate that in dentistry. I think we have too great an opportunity to be a little more sophisticated than that because there are lots of different techniques and we need to, eventually you need to learn them. Um, but if you know how to think about it, see where the spiral is, see where the compensations are, see how much distress a child is in, be able to look at the phenotypic changes in their face, then you can start reasoning. Where do we start this case? And some of the techniques are not really that demanding. Like from a technical point of view, some of them are very easy. And building a network of people you can rely on doesn't require skill. It's just, you know, a, it's a project you got to set your mind to. Start talking to people, meeting people, different, disciplines that can be helpful, each on their own structure, function, behavior piece.
And I think that's why we really find our Zoom meetings after the course very helpful. It's also important to have documentation of your cases, present your cases, get feedback on the decisions made,
Yeah,
and what was working and what wasn't. And then also, we're fortunate to have a study club, an in-person study club, where about every 6 weeks we get together and we treat the patients and
yeah.
get to see the impact and how the cases are doing.
Yeah, I can't wait to
Really,
do
really
that with
helpful.
this class. This class seemed really turned on by the
Absolutely.
end of that
Yeah,
weekend.
they were.
And I know when we talk to them, I want to hear about all the things that they've seen with new eyes, going back to their clinic on Monday, what they saw. And hopefully they're going to be very anxious because there is a point where you want to solve these problems.
Oh, absolutely. I
Yeah,
mean,
and they'll be clamoring for the solution, but there is no the solution.
true. Right.
Yeah. Yeah,
Right.
yeah, yeah. So,
Yeah, and you know what? I like what you said about, the complexity is this is about we have to learn how to think. The actual doing part is, for lack of a better, it's doable. I mean, it's not outside of our skill set. We're really good. We're
yeah,
we're give us something to do with our hands, and we can do it.
yeah,
So that part shouldn't you should not be shy away from this because
yeah,
it represents some techniques. What you should wish to do is improve the way you put things together in your mind, and through repetition and seeing enough cases, I think you can gain confidence and start treating some of these cases. And I mean that's where everybody seemed to be. They're like, man, uh, the successes that you've had that you shared with us were very
yeah,
powerful. And what you were seeing in these kids and how you're talking to them and all the data you have to gather, that sure provides you with all the little data sets and all the little the benchmarks and measurements and all this stuff to
Yeah,
start thinking differently and putting this stuff together.
yeah,
Um, it is a lot to do. It's a big change, isn't it? I mean,
yeah,
you really have to be willing to do the needful changes in your practice. But I think that, for example, I was talking to one person in the course, and he says, "Wow, I'm gonna have to change a lot of things. Yeah, I need to really kind of think about all this." And I
yeah,
said, "Well, do you want to treat these patients?" And he goes, "Well, yeah, of course I do." I go, then making changes in your practice and implementing some new ways of recording things is the pathway to get there. And he says, maybe I'll try some of this, and then circle back and kind of let you know how things are going. And I said, I don't think so. I think you really need to get back into the next course for sure, and stay with the program. So he didn't take much to convince him, but he's definitely committed to the next level,
yeah,
where we get into the stabilizer course, which
yeah,
is
yeah.
coming up soon. I mean, God, it's March 13th, 14th, and 15th.
Good.
So in what is that? My gosh, it's like a month and a half.
Hmm.
Um, and so he was the only guy I talked to that had that perspective. The rest were they're like, wow, I don't really understand exactly everything that just happened to me these 3 days, but I'm coming back. So because it's a big deal.
Yeah.
Like you.
The biggest change is not so much the protocols in the office, it's the protocols between your two ears.
Yeah, I know, right? So
You
true.
know, it's a problem for dentists
Yeah.
because we are trained in a way, and maybe we're attracted to this profession. We are trained to seek perfection. But I don't think there really are very many medical professionals that seek perfection. They seek to make their patients better, but
True.
they realize that they're going to be they're going to be producing a bell curve of results,
Hmm.
which we don't get out of dental school with a bell curve of results.
No chance. Yeah.
Not for restorative preps
Good luck.
or apical fills or anything. We we are we are mindset to be very critical of our own results so that we're constantly looking to make things better
Hmm.
to get it as perfect as possible.
Yeah.
But it has been difficult for me to break out of that
Hmm.
and understand that I am not going to make everybody perfect anatomy, perfect physiology, and perfect behavior.
Right.
And of course, we love to show off those cases
Sure.
where we achieve that. But I think as I teach, I try to show my failures because you learn as much from that as you do from the successes. And also, really, the devil is in the details. When you're sitting there face to face with the patient, having a conversation, or looking at how the patient reacts, sitting with a parent, getting that conversation, get the myriad of stories, legitimate and excuses, that understand all the things that the kids are dealing with. The way you're going to make a decision really requires a certain amount of clinical judgment that we are sort of taught, but the tyranny of this evidence-based medicine and evidence-based dentistry to only do those things where an independent variable has been shown to be affected, it really does not match with reality.
Right.
We are a system, and we're going to need to be thinking on many. many different levels and expectations. Look, there is a movement here in New Jersey to try to reunite medicine and dentistry. We're a conservative state.
Wow.
And I don't know exactly where it's going to go. And it may take a generation before dentistry is accepted back as a medical profession,
Mm,
which it really is. I mean, not that I criticize us for separating ourselves out. We would be under the thumb of the insurance companies
that's true.
if we were always with medicine. And, we want to be able to maintain that clinical independence that many physicians just don't have anymore.
That's so true.
Yeah.
Well, I think we're kind of at the end of our hour, and we're not. I don't have a. We always like to share our lesson of the week.
Mm,
I don't know that I have one other than just to tell you that observing the people in the course was fantastic. During the breakouts that we had between the lectures, or when you were not speaking, Mark was there, and then we'd have lunch and come back.
yeah.
It just was, it never stopped. It was just continuous. The course continued during all of those breakout, those breaks and lunch hours and what have you. It
Hmm.
was fascinating, and everybody seemed to be completely wrapped by the presentations, taking furious notes, even though we told people don't worry about it.
Yeah.
People were documenting everything. It was kind of neat to see it.
Yeah.
One of the guys told me that it was the best course he's ever taken.
Yeah. I love
So
that.
nice to hear, and
Yep.
so that's my lesson of the week is that, when dentists are exposed to something that they didn't previously know, they can
Uh,
be turned on. A switch was thrown on a lot of these people. So that was pretty
Yeah.
nice.
Yeah. Yeah. I have a nice story to tell.
Okay.
Um, this year, my most senior employee retired.
Okay.
She has been working in this practice for 81 years. Let
What?
me repeat that. She
Okay.
started at 17. She is now 97 years old. She has fulfilled every role in this practice and
Wow.
has brought up the practice. Frankly, she brought up me. She started before I was born and
Wow.
worked for a senior orthodontist, then my father, and then me. And just as recently, at 97 years old,
What?
right?
Wow.
She's been handling receivables and finances, and
Oh my
she
God.
actually does it, online and everything. But her personality
Oh.
it is way beyond what her years have ever said, and the way she's touched patients,
Oh.
and the way she's touched my staff over the years, and me and my father. So we had a celebration for her this weekend, and it sent home to me how important the work we are doing is, not from a dental point of view, but from a human point of view, the kinds of ways that we service people, the way we make them feel about themselves, about their children, um, about and the staff, about each other. My staff is so proud of what we do and who we are. Um, I I had a number of staff that had left years ago come back to this because they knew Elaine so well. One of whom said, because she had moved down to Texas, she goes, there is no place that she has ever seen, because I think she's still in the business, that is anything like what we have. And and I know there are lots of offices out there where staff is close and proud of what they do, but that is just such an important thing.
Wow.
And if you feel like you're making a difference in people's lives beyond doing fillings and just putting
Yeah.
out fires. You have an opportunity to really make a difference, in humanity, leave the world a better place for having been here. And
Well,
that's what I want to
that,
promote.
well, that's beautiful, Barry. What a great way to end our podcast today.
Yeah.
And I think we'll be back next week with Mark.
Yeah.
I wish you a good week.
Yeah.
And
Thank you.
let's
You too. We're
look
digging,
forward.
we're digging out of snow on the
good,
East Coast.
good
You
luck.
guys are digging out of football on the West
Oh
Coast.
yeah, don't bring it up. All right,
But good
awesome.
spending time with you, Richard,
You
as
too.
always.
You too. Thanks, Barry, and thanks
Uh,
again for the great job on the course. That was
yeah.
amazing.
All
Amazing
right.
job.
Well, we'll see you soon.
Okay, bye.
Bye.